Thank you, Kim, and thank you to the organizers for the opportunity to speak. So I'm going to take the next few minutes to talk about the impact of physiologic changes in pregnancy on considerations for pharmacokinetics in the context of long-acting anti-infective administration. So I'm going to start with a basic review of different modeling approaches, then what happens during pregnancy that can change the pharmacokinetics of drug, and give a vignette of how modeling might improve PK studies of long-acting injectable formulations in pregnancy, such as with cabotegravir as a sample compound. So some basic review on different PK modeling approaches. Of course, there's non-compartmental approaches that require intensive individual assessments. They're excellent at generating mean pharmacokinetic parameter values from experimental data, but not as good at estimating PK parameter variability, or they're certainly not very well suited to simulation or the incorporation of existing pharmacokinetics from literature. There are compartmental pharmacokinetic models, including population pharmacokinetic models that can use intensive or sparse group assessments and are readily amenable to combining study results. And then physiologically based pharmacokinetic models, which really are oriented towards predictions compared to, from prior models, or generated by prior models and compared with observed results. And as we go from non-compartmental to physiologically based pharmacokinetic models, the number of assumptions increases. And as we go from from physiologically based pharmacokinetic models to non-compartmental models, the time it takes to actually implement and run an analysis moves in the other direction, with non-compartmental being the quickest. POP-PK models are excellent at generating the mean PK parameters, the variability of pharmacokinetic parameters, and for doing simulations, especially across populations and looking at distributions of responses. And PBPK models are very good at the incorporation of existing PK from literature in vitro studies, in particular in vitro and vivo extrapolations. So in terms of physiologically based pharmacokinetic models, there are multiple modules available. These are at least 3 that are commercially available. FISoP, of course, has very nice modules that continue to be evolved, and I know Josh Unadkat has really enhanced the fetal exposure models recently, in particular. PKSim, Andre Dahlman and colleagues have developed multiple models, and they have versions that are available open source in Mobi, so that you can use them without having to purchase a license. And then GastroPlus as well has a module for incorporating changes in pregnancy. The references are at the bottom of the here of the slide, and a lot of the modules were generated by evaluating drugs tested with a wide spectrum of clearance mechanisms, looking at CYP isozymes and some of the UGT isozymes as well. So what are these changes that are occurring in pregnancy that have a direct impact on the disposition of the drug? Well, plasma flow and clearance are altered throughout pregnancy. Volumes of distribution can be affected dramatically, in particular in the 3rd trimester. And metabolizing enzymes, they can increase, such as with CYP2D6. They can decrease, such as with CYP1A2, or they can increase and then decrease, such as has been reported for 3A4, although there is some controversy there because I know there's more recent data that suggests there's a sustained increase. So this table illustrates a list of physiologic characteristics, the direction of change, and the percent change in each of the 1st, 2nd, and 3rd trimester. The numbers in red denote increases of more than 25%. The numbers in blue, decreases of more than 25%. So you can see in particular, if you look at albumin, for example, decreasing 31% in the third trimester, GFR going up substantially in the second and third trimester, and other factors that can interact directly with the disposition of a xenobiotic. So that table shows these parameters changing discretely, but it's much more likely that that these are continuous changes. And so if you consider the physiologic, the parameters used in the Dahlmann model, and look at these across the period from conception to delivery, you can get a much more granular sense of how disposition is changing. For example, we see here albumin decreasing continuously over this period. We have CYP3A increasing and then decreasing, for example. And if you use the PKSIM module, these changes are implemented directly. Of course, you have to incorporate your knowledge of how your particular drug interacts with each of these physiologic changes in order to this. And again, this figure was in conjunction with Edmund Caparelli at UCSD. So in terms of some sample published PK models, again, you see that the main changes that are implemented here relate to either increased or decreased concentrations of metabolizing enzymes. So you need to know the activity and the affinity, et cetera, or binding proteins. So for dolutegravir, the concentrations of UGT1A1 and CYP3A are increased over time in this particular example. And of course, there's an increased unbound fraction over time with the changes in albumin. And the dolutegravir model is the one that we adapted for cabotegravir and rilpivirine. I'll show you the cabotegravir results to explore those impacts more specifically. So in terms of a specific example here, so here we have the desire to evaluate cabotegravir disposition after a long-acting injection administration in non-pregnant cisgender women during their second and third trimesters of pregnancy. So they would start treatment at the beginning of the second trimester, and we'd assume these sort of substantial changes sort of in a very discrete fashion, at least at those threshold points. Again, the model is adapted from the dolutegravir and raltegravir model published by Dahlmann et al. And we obtained specific parameters for cabotegravir from the literature and used published clinical PK data for cabotegravir in non-pregnant cisgender women to validate the implementation of the PBPK model in the non-pregnant state. Then extended this model to pregnancy and simulated dose sequences to evaluate the shifts in disposition that we would anticipate in this population. So this is an illustration of the model structure, and what this basically the non-pregnant model structure is everything above the red box. And then the implementation in pregnancy indicates that these additional parameters that are incorporated. And again, this is available in the Open Systems Pharmacology software suite. So we went to pulled pre-existing non-pregnant or data from non-pregnant individuals, and we've seen this figure several times now today. And so this allowed us to evaluate the performance of the model run in the non-pregnant state, adapted again from the dolutegravir model published by Dahlmann. And you can see that from 100 to these panels show the 100, 200, 400, and 800 milligram IM injections. The of course, concentration on the y-axis, time on the x-axis. The blue dots are the observed data, and the red lines are those predicted by the PBPK model. So they did reasonably well a priori with incorporating this information. So we were reasonably confident, or you could be reasonably confident in utilizing the model. This included scaling the fraction unbound of the drug in pregnancy, and so the general function here is used with respect to changing albumin concentration. And of course, we had to have an affinity that was assumed, and you have to assume properties of binding. But once you do that, if we considered mean albumin concentrations in these different periods of second trimester, third trimester, and 6 to 12 weeks postpartum, you can see that the estimated CAB fraction unbound changes, in particular from the third trimester to the postpartum period, quite dramatically, and will have an impact on at least the observed total concentrations. And Dahlman's group as well evaluated changes in metabolizing enzymes, and here we have the UGT1A1 change that was assumed to be induced by a factor of 1.75 in the second trimester and 1.92 in the third trimester based on previously published information. So we could incorporate this directly and get elimination rate. At the time we implemented this, there wasn't information on the effect of pregnancy on UG1A9, so we did not do a virtual induction in this particular model. So what did this show us? So the left panel shows virtual CAB of LA every 4-week dosing. The red lines are in a non-pregnant woman, cisgender woman. The blue lines in a pregnant woman starting at the second trimester with those changes already of the second trimester starting right at the beginning. We wanted to implement the most extreme scenario and then running those continuous changes across the rest of this period. So you can see that the trough concentrations after the first injection were about 30% lower for pregnancy compared to outside of pregnancy for CAB-LA, and for the sixth injection, so right before delivery, theoretically were decreased about 30% overall. The right panel shows the simulations with variability added in terms of the built-in variability in the PKSIM software that varies expected weights and things like this for this population. And the blue pattern is from the fetal compartment that was included in the model, just to get a sense of what it was in terms of initial concentrations. But we were primarily interested in pregnancy. So these simulations allow us to then adapt a population model. So can we replicate these anticipated changes based on the mechanistic incorporation of these physiologic changes mechanistically, and then use that to ask questions about different regimens and proportions of individuals that might be in different concentration ranges at trough. So in this case, we utilize the model from VIV with Keelong Han, and of course Mark was part of this as well, and effectively adjusted the parameters for the clearance to mimic these changes in pregnancy. And if we look at now the Q4-week switch group simulation, you can see here's the starting at the beginning of the second trimester, every 4-week dosing. And you see this is the third trimester dosing, and then postpartum we are switching off those changes quite dramatically. So you see this increase. We can determine if you could sample the entire world and the model was correct, the proportion of individuals you'd expect in each of these thresholds. So the percentage below the PAIC90 were 0 across all of these based on this prediction. The percent below the 4x PAIC90 were somewhat higher. The first trough was about 11%. If you need the 8x PAIC90 though, you're up to 55% of the individuals. And so this allowed you to sort of make these kinds of explorations. We also use this to evaluate the impact of BMI differences and that sort of thing. But and if anybody's questions, I do have those as backups. So that's if you could sample the entire population. But what if our assumptions are wrong? What if this implementation is not correct? Because we would like to take the first 10 sampled individuals and evaluate the kinetics, and then simulate a Q8-week regimen and make the decision about whether or not to open that study arm. And so if we simulate studies of 10 individuals over and over again, what are the expected results in terms of the distribution of individuals in these different concentration threshold categories? And why would we do that? We want to evaluate the impact of the study design and the sampling variability on the interpretation of the model outputs versus the observations. And so if we do that, again, we simulated 100 instances for those n equals 10 individuals. This is the left panel shows the distribution of the number of individuals below 4 times the PAIC90 for the number of studies. So the first bar here is in 84 out of 100 of the n equal 10 instances, you would expect to see 0 instances of an individual below 4 times the PAIC90. You'd expect in 15 of those to observe 1 individual, and in 1 instance of that study, 2 individuals below that threshold. By the third trough, you would expect that there's an 88% of the time, if you were to run the study over and over again, that you would actually see 0 individuals below that 4x PAIC90, and 12 instances with 1 individual. So you can imagine at the second trough, if you saw 4 individuals with concentrations below the PAIC90, that would suggest that our assumptions are violated in this simulation. We need to go back and think about why there are those substantial differences. So it helps to define extreme findings and maybe help guide decision making on the part of DSMB and other or safety board considerations. So in conclusion, the pharmacokinetic considerations during pregnancy can be well captured using both PBPK and population pharmacokinetic strategies, and there's a complementarity. The PBPK modeling can inform the population modeling, and the population modeling can help inform the PBPK modeling if we have discrepancies here, and help guide decision making. And so some acknowledgements for a lot of individuals involved across many institutions: University of Buffalo, Georgetown, Cape Town, Impact, the SDAC at Impact as well. And I thank everyone for the contributions, and I thank everyone for your attention.